Hi everyone, welcome back to Psychiatry Network Journal Club. Tonight we are hosting Dr. Elisa Gutman, who is coming out of Pennsylvania, and we'll be talking about a PTSD article covering propranolol. So I'm just waiting for her to join us, and if anyone's watching, feel free to say hi. Sorry about last Wednesday. My son was a little bit sick, kind of a lot sick. You know how like things kind of seem okay, and then all of a sudden they kind of get crazy? Like that's what happened right before the video needed to happen. So sorry about that, but we're back this week and we'll reschedule. That was Dr. Lisette Rodriguez Cabezas, who was going to cover a women's mental health topic, which sounded really interesting. Hey Laura, how are you? Okay, so I'm just waiting. I'm gonna see if I can tag Elisa and see if she can join us. Oh, great, there she is. That was fast. All right.
Hi.
Hi there.
Hi.
How's it going?
It's okay. I'm anxious, which I always find amusing when I'm going to teach about anxiety.
Oh,
So,
well, that's okay. It's just you and me tonight. Just
sounds
kidding.
good.
Who knows how many people are actually watching. So thanks for agreeing to do this article tonight. So I love it when we get speakers who are experts in the topic that they're covering, which is the case tonight. So let me tell you guys a little bit about Dr. Elisa Gutman. Am I pronouncing that right, or is it Gutman?
Alyssa Gutman.
Gutman, okay. So Dr. Gutman completed her MD and PhD at Emory University School of Medicine. Her PhD work focused on underlying biological mechanisms related to fear and anxiety, with findings that are particularly relevant to understanding post-traumatic stress disorder. She then continued her training as a psychiatry resident and forensic fellow in the Department of Psychiatry at Perelman School of Medicine at the University of Pennsylvania. Dr. Gutman is the founder and medical director of the Philadelphia Human Rights Clinic, an organization that works in collaboration with Physicians for Human Rights to provide pro bono psychiatric and physical evaluations for asylum seekers in support of their claims for immigration court. Philadelphia Human Rights is the first asylum clinic with a collaboration among several medical schools. Its mission is based on education, volunteerism, and community collaboration. Dr. Gutman treats patients in the outpatient behavioral health clinic at the Crescents VA Medical Center in Philadelphia, where she serves as team leader for the serious mental illness team. Additionally, she teaches residents and medical students as a clinical assistant professor in the Department of Psychiatry at Penn and consults through her private forensic psychiatry practice. She went into psychiatry driven by an interest in trauma and serious mental illness, and she's been a member of Psychiatry Network since 2016 and loves to get a rough consensus on controversial topics in her field, among other things. So thank you for joining us, and go ahead and take it away.
Great. Thank you so much, Christina. Okay.
Yeah.
So the article that we'll be discussing tonight is entitled Reduction of PTSD Symptoms with Pre-Reactivation Propranolol Therapy, a randomized control trial. And the authors include Elaine Brunette, Daniel Sommer, Ahai Liu, David Striner, Jacques Tremblay, and Roger Pittman. And that includes folks from the Douglas Institute at Montreal, McGill University, McMaster University, and the Department of Psychiatry at Mass General and Harvard. The authors have no financial relationships with commercial interests and support through Dr. Pittman, who's the PI on the study, is through a U.S. Army Medical Research Program grant. So to get going into just starting off giving some of the background and introduction that I think will be particularly relevant, and then I'm relying on you because I have my computer to the side, but I'm relying on you to give me the questions. I
Sure.
don't
Yeah,
want to
absolutely.
distract myself from the
Yeah.
paper. Okay. So the interesting thing about this study, to the important relevant background, I think, is that this is among the first reflections in human literature that is targeting reconsolidation learning instead of extinction learning. And so I'm going to give some basic definitions as reminders for those of us who don't think about Pavlov or Skinner all the time. So fear conditioning, fear learning, is among the most basic types of learning that we do as humans. Fear is one of the oldest emotions, if you will. You know, for example, many of the interesting fear studies are done in aplysia, in small worms, right? And so these are really basic brain structures. Fear learning, if you take it down to its very simple, just simple classical conditioning, Pavlovian conditioning, then what you're doing is pairing, for example, a light with a shock, and then the shock is inherently frightening. The light began as neutral, and when you pair the light with a shock repeatedly, then the animal or the person learns to be afraid of that paired cue. So that is called the conditioned stimulus, okay? Extinction learning takes advantage of showing a conditioned stimulus. So in the case, conditioned stimulus, in the case I gave, showing a light, 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 and eventually from aplysia to rats to monkeys to humans, we eventually decrease how much fear we have. So in the case of reconsolidation learning, something else entirely is happening. So in the case of reconsolidation, what's happening is, instead of a trial where, or really an exposure it would be called, where you're giving light, 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 in reconsolidation, you're actually just giving a light cue as a reminder to test how scared the rat or person is. And then just that reactivation of the memory actually makes it potentially labile. And so it gives a bit more, I'm giving a bit more background because I think that this is what's so relevant to psychiatrists. So we're used to having the treatments that we often use for PTSD that have the most evidence base are, say, the psychotherapies far outweigh the medication interventions, and the psychotherapies that we use are prolonged exposure and cognitive processing therapy, are the two major ones that have good outcomes. And those make use of extinction learning. So in those, in PE and CPT, you're having the cue that you're scared to, so your trauma narrative, over and over and over again, and you're using extinction learning. And so in this case, instead of taking advantage of extinction, they're taking advantage of a totally different phenomena, reconsolidation. So what is that? Reconsolidation is actually, I think, really scientifically cool and interesting, because the groundbreaking paper that came out about this was in 2000 by Karim Nader out of when he was working in Joe Ledoux's lab. And it was in 2000, and that was like my second year as an MD PhD student in a learning and memory lab. And this article came out in Nature, and our brains all blew up. So there was a really old literature on this, and then this came in, and he was able to show, and this was in rodent model, that just showing the light once and then giving a nesomycin, so after reminding the animal, I'm afraid of that light, and then giving a protein synthesis inhibitor, the animal, when tested later, was no longer afraid of the light, which is just a totally different thing. The issues with extinction learning, and this is what the authors go through in their introduction, is that extinction learning has some caveats to it. So extinction learning is a new learning process. It's not an erasure of memory. It's not a forgetting. So with extinction learning, when you're taking advantage of extinction for a treatment intervention, it has the possibility and the vulnerabilities of what extinction has as a vulnerability. So there's several of them, including it's really the 3 R's, so renewal, reinstatement, or spontaneous recovery, which we don't need to get into the learning theory aspects of that. But the short version for psychiatrists is that there is ample evidence that extinction learning is a new memory that says, the light's not so scary anymore. But that basic fear memory, lights are scary because I get shocked, is still there. In this case, with reconsolidation, what's actually happening is forgetting. And so it's taking advantage of a totally different concept, which is that it had been thought before Nader brought this work out again, after many years of it being dormant, it was thought that once a memory was consolidated, particularly a fear memory, because they're so strong, that once it was consolidated, it was there. And the best you could say for getting rid of it would be to use extinction learning and to make a good inhibitory memory. But when this came out in the rodent model and was then followed up on, it was clear that actually reconsolidation is an actual phenomena that occurs. That when that memory is brought into the mind, there is a period of lability. And so instead of the consolidation being permanent forever, I'm never going to forget how scary the light is, there's actually a period of vulnerability of that memory once it's reactivated in which it can be modified. And I, for one, think that that's quite remarkable. So I think that that's a good extensive background. I think that gives the basics for what's necessary to understand then in going through the methods here. So
yeah,
I'm going to move us forward into methods. So the authors explained a few studies that they had done initially, some background studies that are relevant. So when they were testing the hypothesis initially, they did there was an initial study of propranolol treatment that was also an RCT, and they did a script preparation session where somebody was instructed to make a trauma script, and then they received propranolol after writing that script, and then they were tested a week later. And they found in that smaller study that there were decreased physiological responses to the trauma memory, and that there was a moderate decrease in symptoms of PTSD. And that was only just with doing this with one time. So they thought, well, maybe more times we would get a more robust finding on symptoms of PTSD. So they did an open label study, which was promising. And that led them into doing this RCT that is presented in the article we're reviewing now. So the methods employed here, there were 61 individuals randomly assigned to groups. The inclusion criteria included treatment seeking, having PTSD symptoms for at least 6 consecutive months, and having greater than or equal to a 44 on the PCLS, so PTSD checklist. The exclusion criteria, because this is a study employing propranolol as a medication intervention, exclusion was for systolic blood pressure less than 100, heart rate less than 55, some kind of medical diagnosis that would contraindicate a relatively high dose of propranolol being used, so something like asthma or diabetes or an arrhythmia, CHF. They also excluded folks with psychosis, bipolar disorder, TBI, substance dependence that was active, or acute suicidality. And I thought this one was interesting. One of the exclusion criteria was involvement in PTSD-related litigation. So that led to exclusion, and also strong dissociative tendencies, which I think that they chose because propranolol could worsen that sensation of dissociation, and we know that that is a particularly vulnerable psychological state. Okay. So the testing that they did, the way that they were monitoring their study outcomes was using the PCLS, so the PTSD checklist, and it's the specific one. This is a self-report measure. And then they were also using a CAPS. So that's a clinician-led standardized PTSD clinical scale. And they used those as 2 outcome measures so that they had a self-report measure and also a clinician-rated measure. And the self-report measure was done weekly through the trial, and the clinician measure was done at the beginning and then following the final treatment session. Okay. So the dose of propranolol given was 0.67 mg per kg of conventional, so a short-acting propranolol, and at the same time, they give a mg per kg of a long-acting. The first time that they administered it, they actually staggered the short-acting versus the long-acting so they could see if somebody had a reaction to the short-acting, and then they wouldn't give the long-acting formulation. And then after that, subsequently, they gave both at the same time. And the peak of the short-acting propranolol is at 75 minutes after ingestion. So they timed it, so they gave the propranolol, and then it was actually 90 minutes after it was given that they did the treatment intervention. The medication was given by a nurse, and vitals were monitored Q30 minutes up to 90 minutes to make sure that the propranolol wasn't having an adverse effect in terms of too low of heart rate or too low of blood pressure. And in terms of who stayed in the study, there were some excluded due to side effects, relatively mild side effects, but they still wound up not including them in the continuation phase. And then the per protocol participants who ended the study, there were 15 in each, the placebo arm and the treatment arm. And there had been about 30 on each arm going in. So there was attrition in both groups through the study. So how they did the trauma reactivation, they had doctoral level therapists that were working in the treatment arm and the placebo arms. And 60 minutes for the first session, 60 minutes after ingesting the study med, the participant was instructed to write a one-page narrative. And this will be familiar for those who have done prolonged exposure or cognitive processing therapy with folks. So the one-page narrative was done in present tense, first person singular, focusing on the events that were most disturbing in the trauma, and including 5 or more bodily sensations that were experienced in that present first person singular. And then at 90 minutes, the participant was instructed to read the narrative aloud once, just one time, quote, as if they were back in the event. And then at the end of that reading the trauma narrative, they were congratulated on doing something difficult and sent on their way. And there were 6 treatment sessions. So in the subsequent visits, 90 minutes after the propranolol was given, they were asked if they needed to rectify their trauma narrative or if they needed to supplement it in any way, which is, again, something done with prolonged exposure and something done with CPT, or there are modifications that you need to make to your trauma narrative. And then they would, again, read the narrative aloud once, which would take about 10 to 20 minutes. I think what's really essential, so pausing as a moment as psychiatrists, so for those who know about how PE works and know how CPT works, those are, as I said before, employing extinction learning. And in those, it's essential to repeat the narrative over and over again. And so in this case, what's so different is the narrative is said once, and that's it. And there's no psychotherapy, if you will. So there's no processing post reading the trauma narrative. There's what could be seen glibly as a pat on the head. That was really hard. Good job for doing that. And so that was really important that they designed the study that way, because they were making sure as best as they could that extinction learning wouldn't happen. So it would be too confounding and too confusing to know how to interpret their results if there were these extended sessions where you're repeating the trauma narrative at length, because that would have the capacity to actually be an extinction trial. And so, or extinction training session rather. And in this case, they were careful, I think, in many ways to ensure that this was truly a reactivation of trauma. I think another moment just to stop and pause and think about why that's so significant. Normally, if somebody is exposed to their trauma narrative in such a short amount without the ability to process and complete, that is actually bad. for PTSD symptoms. If anybody out there watching is familiar with the failure of debriefing, that was tried as an intervention, as a postvention for post-trauma for PTSD, and it's repeatedly been a tremendous failure, probably because someone goes to a high anxiety state and is kept there instead of in therapeutic interventions where they're typically allowed to decrease. But in this case, the person's probably likely leaving at a high anxiety state, but with propranolol on board. So I'm going to move us now past methods and into the a little bit about how they did the data analysis, because that winds up being really important here. So because of the rates of attrition in both groups, they only had CAPS follow-up for 14 participants. So they show us the data in two different ways. They show us the data using data imputation that accounts for missing data, and they show us an intent to treat analysis, and they also show us an analysis that's done per protocol. So in those 15 placebo folks and 15 treatment intervention folks who had the whole per protocol experience, and they give us the endpoints for both. And that winds up just being helpful as we go through the results. So I'm not going to get into, and you can make me if you want to, but I'm not going to get into much about the statistical analysis. I'm not a statistician. Yeah. I'm not going to explain it very well.
That's okay.
Okay. Sounds good. Okay, so jumping into the results. So first, giving the results of the CAPS. So that is the clinician interview for PTSD that was done. Let me just, so going into the data from the CAPS, they found in their, so they actually found, I'll just give the basics first. So for both the groups of folks who did the 6 treatment sessions, propranolol versus placebo, they found decreases in symptoms of PTSD in both the CAPS and the PCLS, and they found that in both the treatment intervention arm and in the placebo arm. So it turns out that, and I find it particularly interesting that this was helpful in the placebo group, that even just this very short session of trauma narrative discussion with someone being nice to you and saying that was really hard, great that you got through it, actually wound up having a reduction in symptoms of PTSD. So in both arms, the outcomes were much greater for both the CAPS and the PCLS for the intervention arm with propranolol. So for the group that received the immediate and the long-acting propranolol before reactivation of their trauma memory. And so just to give the numbers and get some idea of the size, for the CAPS, there's not a table for the CAPS data, or not a figure rather for the CAPS data, but the changes are listed in table 2. So if anyone's reading along with the article, table 2 has the data listed, and then we'll look at the figure next. So for the CAPS data, for the intention to treat for the propranolol group, the effect size using a Cohen's d, which is a measure of effect size, was 1.76 for the propranolol group. And as a reminder for those who don't think about Cohen's d most of their lives, a large effect size is a 0.8, and this effect size was 1.76 for the intention to treat. And for the per protocol, 1.64. So this is a very large effect size. Interestingly, the placebo arm for the intention to treat was actually an effect size of 1.25, which ain't bad. And the effect size for the placebo group was 0.72. Figure 2 actually goes through the data from the self-report measure, so from the PCLS. And so for those looking at the graph, and I'll explain it for those who aren't, the first graph in figure 2, A, is looking at the intention to treat analysis, and B is looking at per protocol. The Data, the results are very similar, which is also reassuring that either way that they wound up trying to look at the data, accounting for the confounding from the attrition of study participants, that both ways actually showed good data. And so for the intention to treat analysis, just looking at percents for pre versus post measures, they found a 56% reduction in PCLS reported symptoms of PTSD, 56% reduction. And in the per protocol, it was 53%. In the placebo group, it was 15% or 10% in the per protocol. So the comparison there, just thinking about the intention to treat analysis, which is probably the maybe the purest way, you may say, to think about these data, because you really want to look at when you have attrition, you want to account for that when you're looking at your study data. And so 56% in the propranolol arm versus 15% reduction in the placebo arm. So these are really impressive data, to be quite clear and frank about it. So what do we think about this in terms of discussion? Okay. So it turns out that PTSD participants who actively recalled their trauma by reading their trauma narrative and were given propranolol had a decrease in symptom ratings compared with placebo, true for both the CAPS, the clinician rated, and the PCLS, the self-report. So both the clinician and the participant. The effect sizes that were shown were really quite good, comparable to results seen with CBT studies and with SSRIs. But there are some, I think, important limitations that the authors reviewed, and I agree with some of the limitations that they listed, and I'll give my own as well at the end. So the results are consistent with a suggestion that reconsolidation would be the mechanism underlying what happened. But humans are much more complicated than, as it turns out, aplesia or rats or monkeys even. And so we can't really know that reconsolidation was what happened here. There's no way of knowing that. It's the grand unknowable of science of the brain. But we can fairly infer that reconsolidation occurs. And also inferring reconsolidation because that typically requires that the memory is going to be lower. So, and that decrease is going to be maintained, but we don't have any data further out. So if they could come back and tell us in a year if there were still decreased memory, decreased PTSD symptoms in response to the trauma narrative, then that might even tell us more if this was really reconsolidation as opposed to extinction, because extinction, if it were extinction, symptoms might creep back over time. And it's certainly the case too, because there was such attrition in the study, and it's not totally clear why, the follow-up data are really not that useful. So the numbers wind up being pretty small at the end. Even the per protocol analysis I had said earlier is just 15 and 15, which is a pretty small study. It's a wonderful study and a really elegantly done study. And so I think it's very promising. So what do I think about this in terms of how it could impact our treatment? I am, for those who know me, typically like glasses 3/4 full kind of lady.
Oh, that's great.
So typically an optimist, but I'm really quite pessimistic about how something like this would be employed practically. And I say this for reasons. So there have been studies for years, like literally since I started my MD PhD program in '99, but before that even, there have been studies showing using medication combined with psychotherapy interventions that have had really awesome data. And I've never seen anyone do it in clinical practice ever outside of a study. And So
Yeah.
I think that's for many reasons.
Yeah.
I I think one of the reasons may be that not all, and I certainly don't know what the number is, but probably not most psychotherapy interventions are done by psychiatrists. So you have folks who can't prescribe medication doing a lot of psychotherapy, and this kind of um, interesting intervention doesn't happen for that reason. I also think there's just an inherent split between what scientists think is really cool for a research study and what actually makes it to prime time. I mean, there was a study showing you could decrease sessions of psychotherapy for fear of heights to like one session, adding D-cycloserine. I think it was one session. If I'm being videoed, I should quote things accurately, but and that's never done still, right? And like one session of therapy, you'd think we would do that, and we don't. So I'm skeptical that this would be used. Why I think if they were able to show this in a larger group, why I think it would be really cool if it were used, is because you wouldn't necessarily have to be doing this with a particularly skilled psychotherapist. The intervention is write your trauma narrative with these instructions, say your trauma narrative, receive warmth and empathy for having done so, which I would think doesn't require the kind of skill and the kind of level of training that being a good PE therapist or a good CPT therapist does. So it could potentially be used more widely. And the very fact of the possibility, if this really is reconsolidation and not some other kind of learning phenomena, then that means that you're actually helping someone forget how scared they were about likely the worst day of their life, which chokes me up a little because that would be a real gift to be able to give to somebody who'd experienced severe trauma. Okay.
Yeah. Oh, okay. No, thanks. That was really insightful and very concise. Thank you. And you made it easy to understand. I work at the VA also, but I don't actively treat a lot of PTSD because I do consults, so do a lot of other things. But I do think that PTSD treatment is difficult. I remember having one particular case in residency with a female, and she had had sexual trauma, and it was so hard for her to even think about recounting any of it. And I was just a resident at the time. I really didn't know what to do with her. So I could see what you mean about why some of these things aren't picked up. I think it's an intimidating illness to take care of because you're worried that if somebody starts to unravel in front of you and you're not able to help manage it, like it's kind of scary. So I can understand that.
I understand that point. I think what I would say in terms of encouraging, particularly if we have any trainees that are
Yeah,
listening or will listen,
that would be great.
I think that I think that's natural and normal and probably is everyone's initial reaction when working with someone with trauma, but it's not well founded for a few reasons. So one is this idea that your patient with severe trauma needs to be handled with kid gloves or is like a piece of fine china. The individual that you're seeing who's experienced severe trauma is coming into your office after having experienced severe trauma and is almost definitely one of the most resilient people you will have met that day, if not that month, if not that year. People with severe trauma lived through it, and even when they're having severe symptoms, they're making their way to you. These are not folks that their trauma was
That's a good point.
worse
Yeah.
than you could be to them.
Yeah.
And in terms of thinking that something is so severe or even that symptoms are so severe, it's something that comes up a lot. And I've actually seen it come up in Psychiatry Network, is this idea that someone's trauma is too bad. So we should just let them, they're just bad, they're never going to recover. That's just joining someone's avoidance And it's frankly wrong, and the data don't support it at all. So severity of someone's trauma does not predict the outcome of trauma treatment. Those aren't correlated.
Okay.
So it's totally possible to have somebody with horrible trauma recover completely.
Well, that's very encouraging. Thanks. I'll definitely be paying more attention to that in that case. And I don't see any questions right now. There was a shout out from Sarah Gelbach D. Michelle for
Sarah.
your for use of aplesia.
Nice.
And she was saying hi.
And she's a psychiatrist at the same VA I'm at.
Oh, okay, great. So thanks again. And if anyone has any questions, feel free to post them and we'll try to have them answered in the next day or so. Otherwise, we'll see you on Wednesday night. I'll be doing another video then. All right, see you guys. And thank you. Okay,
Thank
bye.
you. Bye.